Assalamu alaikum and hello everybody. Thank you all for joining us for hearing this insightful lecture, which is the role of sympathetic blocks in chronic pain, and it will be delivered by Dr. Sadaf Mushtaq. She is a consultant anesthetist in pain medicine at Call Associate Hospital, Lahore. Thank you for joining us, Dr. Sadaf.
Thank you very much, Dr. Aksa, for the very nice introduction and brief introduction. Well, Call Associates is just a group of anesthesiologists who are working together, and National Hospital and Medical Center is my workplace. So, can you see my screen now, Dr. Aksa? And am
Yes,
I audible?
yes, Dr. Sadaf. Before we begin, I just want to say a few words. So I would like all the participants to mute their mic so Dr. Sadaf can deliver her lecture uninterruptedly. And if we have any questions, we can ask her by the end of the lecture. So inshallah, she will be able to answer by the end of the lecture. I will share the Google form link in the end so everyone can fill the form and get their certificates. So thank you, Dr. Sadaf, for joining us and volunteering for this lecture. And we can begin, Dr. Sadaf. Thank you.
Thank you so much, Dr. Aksa, and thank you, PSA Karachi, for inviting me. In next few minutes, inshallah, we'll be learning about the role of sympathetic blocks in chronic pain in view of recent updates in guidelines. We all know that pain is often called chronic when it persists for months or even years, continuing beyond the usual recovery time from an injury or illness. The sympathetic nervous system is a part of the autonomic nervous system, and it actually controls the body's involuntary activities. So the sympathetic nervous system is specially and pathophysiologically related to acute and chronic pain. But before we know how our sympathetic blocks interventions play their role in treating and managing pain, we need to know and have a clear understanding of location and anatomy of the sympathetic chain. So we'll be starting with the anatomy and very basic anatomy and brief anatomy and the physiology of the sympathetic system, how it actually works. So the central sympathetic nuclei are basically located in the intermedial lateral nucleus of the lateral gray column of the spinal cord. It extends from T11, T1 to L2 and L3 levels. So basically it is the thoracolumbar sympathetic chain. And their axons leave the spinal cord in the ventral roots and form a white premise shortly after the ventral ramus separates from the spinal nerve. Here we all can see that this is basically the gray matter and the sympathetic nuclei is basically lie over here. So these myelinated white remi then proceed to either paravertebral or the prevertebral ganglia. The paravertebral ganglia form the sympathetic trunk along the both sides of the vertebral column. It consists of almost 20 to 24 paired and interconnected ganglionic nodes that join together at the coccygeal level to form the terminal unpaired node of the parasympathetic chain known as the ganglion impar. Here we can see that they are located in the form of the pair, and this is the terminal most portion, which we know as ganglion impar. The next one is the prevertebral ganglia, which are also known as the preaortic ganglia, and they are organized in the plexus surrounding the major branches of the abdominal aorta. They are known as the celiac ganglia, the superior mesenteric ganglia, the aortico-renal ganglia, and the inferior mesenteric ganglia. The preganglionic white rami reaches these ganglia after transmitting through the paravertebral ganglia and the abdominopelvic splanchnic nerves. And the postganglionic fibers leave the ganglia in the form of the unmyelinated gray rami and either join somatic nerves or form the visceral nerves. So here we can see why this visceral pain or this the smooth muscle pain is connected with how they get connected with the sensory nerves. The afferent input of these sympathetic ganglia is relayed via general visceral afferent fiber that carry the pain and reflex sensation from internal organs to the dorsal horn of the spinal cord. From the sensory receptors located in the organ of origin. This input follows the path to the corresponding sympathetic ganglion and into a mixed spinal nerve along the white rami on a course to the dorsal root ganglion. Here we can see the dorsal root ganglion where the cell body of the general visceral afferent nerve is located. Such anatomical location and the distinct spatial separation of the sympathetic and the somatic nerves structures, they allow for the selective nerve blocks of the sympathetic ganglions. So here they are combined together, but over here, this is the spatial segregation, and the sympathetic ganglia are isolatedly located over here. So we can block them over here without the sensory and the motor blockade. So what are the indications of sympathetic blocks in the management of the chronic pain? They are used to treat the visceral pain, the vascular or the ischemic pain. Some neuropathic painful conditions are also used. Some neuropathic painful conditions also use the sympathetic blockade for their treatment, which includes the postherpetic neuralgia, the refractory painful diabetic neuropathy, the phantom limb pain, and the CRPS. Hyperhidrosis, acute treatment of the electrical storm, and the post-traumatic stress disorder treatment as well. The diagnostic sympathetic blocks are used to confirm the presence of the sympathetically mediated pain. Longer-acting therapeutic blocks can be performed by injecting neurolytic substance or repeated local anesthetic administration. So before we move on, what are the evidence that suggests the use of these blocks in the management of the chronic pain? Let's quickly go through the contraindications. There are few absolute contraindications, which some of them are, we all know that the allergy to the medications planned to be used, or the refusal or inability to of the patient, inability to sign the consent or the cooperation by the patient. And the other relative contraindication includes the infection or the malignancy at the site of the needle path, as it increases the risk of the dissemination, or anticoagulation and the coagulopathy as addressed by ESRA guidelines. So there are some other conditions of the blocks which needs to be evaluated before we go for the block. For example, if we are planning for the celiac plexus block, we need to see if the patient is taking any antihypertensive drugs like diuretics or any kind of bowel obstruction or not. So the ESRA guidelines share and suggest or count sympathetic block as intermediate risk of the bleeding during the procedures. So if you are planning to go for the sympathetic block, we need to see that the patient, the coagulation profile of the patient, and these blocks are considered as an immediate risk of bleeding by the ESRA guidelines. So risk versus benefit need to be weighed before you go for the interventions. Now, next comes the indication of the sympathetic blocks. The sympathetic blocks are given for the treatment of the visceral pain. Foregut and midgut structures, they are innervated by the celiac plexus block. So blocking this plexus may relieve the pain and the nausea, often associated with malignancies of the organs, as we have mentioned earlier. Next, the hindgut structures, like descending sigmoid colon and the proximal rectum, they are being innervated by the superior hypogastric plexus. So a blockade of this ganglion will be helpful in relieving the pain from these visceras. Then comes the inferior hypogastric plexus, which may treat the pelvic and the genitalia origin pain. This procedure is, however, not recommended because of the presacral location of the inferior hypogastric ganglia. Instead of this, we can go for the ganglion impar block, which is usually given for the distal structure of the pelvis, as they are all innervated by the ganglion impar block. Ganglion impar, sorry. The thoracic paravertebral sympathetic chain transmit nociceptive input from the thoracic viscerals. Due to the proximity to the somatic nerve and the complex surrounding anatomy, the thoracic paravertebral sympathetic chain is really blocked. However, the anatomy, as we all know that there is the anatomy, according to the anatomy of the thoracic vertebra, and the thoracic sympathetic chain, there is a high risk of the somatic block and the other complications. So this block is rarely performed. Next comes the vascular pain. For upper limb pain or upper limb vascular pain, we usually go for the stellate ganglion block. However, pain from the tissue ischemia or pain from the lower limb, we go for the lumbar sympathetic blocks. Most patients responded well with the significant decreased pain and increased perfusion of the affected extremity after you give the block. And if later on you find out the good results with the initial diagnostic block, we can plan for the neural ablation or the denervation of the lumbar chain in these patients as well. Next come the evidence about the use of the sympathetic blocks in neuropathic pain. Here, when I just searched the literature, I found very different and very updated data. Recent data about the use of the sympathetic block in the post-herpetic neuralgia suggests that the allodynia and the pain from herpes zoster of the trunk and extremity may be relieved better with the paravertebral blocks or with the epidural block instead of the sympathetic block. For example, if the patient is having the post-herpetic neuralgia, so instead of giving the sympathetic block in first place, the results were better with the use of the epidural and the paravertebral injections, with local anesthetics and the corticosteroid injections. The efficacy of the sympathetic block for the treatment of post-herpetic neuralgia remains controversial. However, there was one case report which suggested that the lumbar sympathetic block may be efficacious in treating refractory painful diabetic neuropathy condition. Some of the studies are about the treatment of the refractory painful diabetic neuropathy conditions, but only one case report showed the significant pain relief after the sympathetic block in a patient with a painful diabetic neuropathy. Phantom limb pain is also a type of the neuropathic pain. It is also hypothesized to be partially sympathetically mediated pain and pathophysiologically similar to the complex regional pain syndrome, especially CRPS type 2. But a recent case series and the pilot study suggests that the effectiveness of the sympathetic blocks in providing stump pain relief is not that effective. So the role of the sympathetic block in the phantom limb pain remains unclear so far. Sympathetic nerve blocks are not indicated for the treatment of the chronic pain related to the CRPS. CRPS, according to the practice guidelines from the American Society of Anesthesiologists, Task Force of Chronic Pain Management, and American Society of Regional Anesthesia and Pain Medicine, that is ESRA, they suggest that for the patients with the CRPS, the sympathetic blocks can only be used in refractory cases. Both stellate ganglion block can be used and the lumbar sympathetic blocks can be used. The stellate ganglion can be used for the upper extremity CRPS, and the lumbar sympathetic blocks, as we all know, it can be used for the low extremity CRPS. But we need to keep in this thing in mind that it is only for the refractory patients of the CRPS. There are certain other clinical conditions which may require the sympathetic blockade. One of them is the hyperhidrosis. I couldn't find out a lot of details about the use of sympathetic ganglion blocks for the hyperhidrosis. However, there were a study of 69 patients, and they found it to be helpful. However, treating the patients with the plantar hyperhidrosis. Next come the use of this stellate ganglion block for the acute treatment of the electrical storm. So this is also new for me. When I found it, a recent trial which was published in 2019, they showed that the up to 90% efficiency of left-sided or bilateral stellate ganglion was seen after they treated the patients with the electric storm. Um, It is actually the, just for the better understanding, I would like to elaborate the electric storm. What is electric storm? It is actually a severe form of the recurrent sustained uh, SVTs with a greater than or equal to more than 3 episodes in 24 hours. And it is called as electrical storm. And it is also associated with 2 to 8-fold increase in this sudden cardiac arrest. So a recent prospective study was done, and they give the stellate ganglion block in these patients, and they found actually that it is 90% efficacious. Next come the use of the stellate ganglion block in the patient with the post-traumatic stress disorder. It is also found recently that they conducted the few randomized controlled trial and found out that in the patients with the PTSD, the results were better after they used the stellate ganglion block, which means that the patients after the stellate ganglion block was given, the patient recovered with the PTSD earlier. Initially, it was hypothesized that the right-sided stellate ganglion block may locally decrease the nerve growth factor level, which leads to reduction or even the reversal of the sympathetic nerve sprouting in the plexus and among its anatomical connections. This later on in turn results in the reduction of the cerebral norepinephrine release, and the block may directly interrupts this signaling of the norepinephrine release, which may be uh, helpful and may be responsible for processing emotions such as anxiety and the fear. So basically, by applying this block, they are the sensations uh, which are being transferred in the amygdala. It is being stopped. So these are the two new advances and the uses of the stellate ganglion block. So in next few minutes, we'll be just quickly go through the indications of the commonly used blocks and their techniques. As we all know and we already have discussed that stellate ganglion block, it is used for sympathetically mediated pain, and it is also commonly used for the post-radiation neuritis pain. And for the vascular insufficiency, hyperhidrosis, post-traumatic stress disorders, and the acute treatment of the electrical storm. So this is the this is the stellate ganglion, which is located. We all can see that it is located right in front of the transverse process of the C7 vertebrae. So despite its location at the C7, the stellate ganglion block is actually performed at the level of the C6 because of just to prevent the or decrease the incidence of the pneumothorax and the vertebral artery puncture. So under ultrasound guidance, we get this kind of image. We just need to stay in front of the locus coeli muscle. And when we go with the fluoroscope, we may get this kind of the image. So when you give the block and you'll see or will find out the evidence of the blockade. For that purpose, we'll need to look for the Horner triad, and there are other subjective and objective tests which are recommended to see. So in Horner triads, we also know that when the block is effective, we may see the ipsilateral partial ptosis, meiosis, and the facial anhidrosis. And the subjective signs includes the pain relief. There is increase in the temperature. Patient complains of the increase in the temperature of that limb, and there is decreased perspiration. And there are certain objective tests which are recommended, and they need to be done. There are certain complications and adverse effects which often occur with the stellate ganglion block, and this includes the Horner syndrome, the impaired vision, the stuffy nose, and we need to keep in mind the local anesthetic systemic toxicity, since we are working very close to the vascular uh, in this area. So damage to the any surrounding vessels can occur, bleeding and hematoma can occur, and there are always chances of vascular embolism, pneumocapillus, and perforation of trachea, esophagus, chylothorax, and pneumothorax can also occur. So it was a systematic review which was done, and they uh, was it was recently published, and they find out that despite the image guidance, there were a lot of systemic complications. And this data was collected over a period of, they started collecting this data in 1990, and they collected it till 2018. So they collected it for like almost 27, 28 years. So they find out that the most common complication was hoarseness and lightheadedness. And despite we are performing these blocks under image, there are chances of this list of the complications. And there are some local complications which can also occur, starting from the hematoma, blood aspiration, intrathorax bleeding. We can have the dual puncture and transient neurological injuries. So next comes the celiac plexus block. Celiac block is indicated for the chronic intractable pain, and mostly from the organs of the foregut, as we already have discussed it. So mostly malignancies and the foregut and the midgut structures, when they cause pain, we give celiac plexus block. So evidence suggests that celiac plexus block is the only block which has multiple grade 1B evidence, that it has a strong recommendation and moderate quality evidence. There are multiple approaches to block this celiac plexus. It can be done under CT guidance and the fluoroscope guidance, and it can be done anteriorly, laterally, and posteriorly. We being pain physicians, we mostly use the posterior approach. And this is the image that you get once you are giving the celiac plexus block under fluoroscope. So the most common adverse effect or complications were the local pain, which are very much common during celiac plexus, diarrhea, and the hypotension. So that's why I also initially mentioned that if you're planning to go for the celiac plexus and your patient is on the antihypertensive medication, especially the diuretic, you need to stop it. And also, if the patient is having the acute abdomen, or if you are suspecting that they are gut obstruction, then we should not go for the celiac plexus block, as it increases the gut motility and your patient can end up in having more pain and more complication. There are some rare complications which can happen with the celiac plexus. Next comes the splanchnic nerve block. So the only indication for this splanchnic nerve block is to use it as an alternative to the celiac plexus block. There are certain situations where their celiac plexus block cannot be given, like the distorted anatomy, as we often see in a patient with malignancy because of the preaortic adenopathy, or because of significant scarring, or because of the big size of the tumor, especially in the celiac trunk origin. So in these cases, we may go for this splanchnic nerve block. Splanchnic nerve block can also be given if the celiac plexus block was unsuccessful because without any reason. But once you fail to achieve a celiac plexus block, it's advisable and recommended to go for the CT guided celiac plexus block. But if it's not approachable by any means, then it's better to go for the splanchnic nerve block. The splanchnic nerve block is very much similar to transcranial celiac plexus block approach, But the difference is that the insertion of the needle and advancement of the needle is anterolateral border of the T12 vertebral body. While doing the celiac plexus, we go and target the interior lateral border of the L1 vertebrae. The stentric block we target for the T12 vertebrae. So here you can see that the needle is targeting right in front of the T12 vertebrae. This is the ribs. The commonest complication of the spastic nerve blocks are identical to those of the celiac plexus block. However, since it's a little higher up area, there are high risk of pneumothorax and high risk of somatic nerve injury. Next comes the lumbar sympathetic blocks, and the indications are the vascular insufficiency of the lower extremities and the sympathetically mediated pain of the lower extremities, kidneys, ureters, or the genitalia. So we can give it in the CRPS, intractable renal colic pain, urogenital pain, post-amputation of stump pain or phantom limb pain, frostbite, hyperhidrosis, or acrocyanosis. The lumbar sympathetic ganglia consist of 4 or 5 paired nodes on the anterior lateral surface of the L1 to L4 vertebrae, with the most dense at the portion of the L2 to L3 level. So we'll be starting with the L2, L3 level, and you can go a level above and a level below. The most common complication and the adverse effects are the hypotension and the bleeding and the pain, soreness at the site of the injection. In addition to the other sympathetic block complications, the groin pain and the paresthesia, which we know as the genitofemoral neuralgia or genitofemoral nerve injury. This is very much common with the lumbar sympathetic block. Damage to the viscera may also occur if the needle penetrates the retroperitoneal organs like urethra and kidneys. And there are always risk of intravascular, epidural, or intrathecal injections. Next comes the superior hypogastric plexus block. So it is mainly indicated for the chronic visceral and neuropathic pelvic pain, which is caused by the trauma or surgery. It can also be given for chronic endometriosis and postoperative adhesions or the pelvic inflammatory conditions, the interstitial cystitis, sympathetically mediated pelvic or rectal pain, or post-prostatectomy, penile and urethral pain, and also for the malignant pain of the pelvic and rectal viscera that is unresponsive to the conservative treatment. Where it is located and how to give it, the superior hypogastric plexus is located retroperitoneally and it is located anterior to the L5 and S1 vertebral body junction. The common and the internal iliac arteries and veins are located on either side of the plexus. So there is a high chances of damage to these vessels. So this is the fluoroscopic lateral view showing the needle and the contrast. Since we have discussed that these ganglion are located very much near to the nerve roots and the spinal cord. So injury to the nerve root and spinal cord is the most common complications. And bleeding and retroperitoneal hematoma is one of the most common complication that we encounter. There is always chances of perforation of the pelvic pain and intravascular, epidural, or intrathecal injections. Last of them is the ganglion empire block. And the indication for giving this is the sympathetically mediated pain in the sacral, rectal, anal genitalia, or the pelvic perineal pain. It can be because of the malignancy, or it can be because of post-herpetic neuralgia, or it can also be given in the patient with coccydynia or pain secondary to the endometriosis. It is basically this ganglion empire is located anterior to the sacrococcygeal junction. It is the most caudal ganglion of the sympathetic chain, and it provides the partial sympathetic innervation of the genitalia and the pelvic viscera. So this is the lateral view, and here we can see the sacrum. This is the sacrococcygeal ligament, and this is the first and sacrum coccyx. So the needle entry point is between the first and the second coccyx, and here we can see the contrast bed. This is the position of the ganglion empire. The most common complication that we encounter while giving the ganglion empire block is the rectal injury, and there are always chances of the infection, fistula formation, and sacral nerve root injury. So if we summarize all these sympathetic blocks, we have seen so far that sympathetic nervous system, it has a role in the vascular, visceral, and neuropathic pain. Though its pain in neuropathic pain is controversial, its role in neuropathic pain is controversial, but the block of the sympathetic ganglia can offer pain relief in sympathetically mediated pain. Neuropathic pain, since we all know that it is a multifactorial pain, it is not completely abolished by sympathectomy. So there is no consensus about the optimum technique, the interval between the blocks, and the duration of the treatment. And there is no convincing evidence so far to recommend one type of imaging over the another type. There is one consensus that these sympathetic blocks need to be done under image, but which image is better, ultrasound or fluoroscope? It is not, there is no clear-cut recommendation. However, the ultrasound guidance is favored for the superficial structures like a stellate ganglion, and the fluoroscope is preferred for the deep axial structures like lumbar sympathetic blocks. Multiple studies show that the sympathetic blocks with local anesthetic alone without steroid may be adequate for the pain relief. Sometimes it happens that you give one shot to diagnostic block and we add some steroid in it, and the duration of the block sometimes exceeds the normal time of the local anesthetic. So this diagnostic block acts as a therapeutic block. The ESRA guidelines clearly recommend that the local anesthetic alone is sufficient for performing sympathetic blocks for the pain relief. And there is grade B evidence of imaging guidance with ultrasound or fluoroscope, which, as I also mentioned earlier, that they recommend to use any of them, ultrasound for the superficial structures and fluoroscope for the deep structures. Thank you so much. The house is now open for questions or any comments.
Thank you, Dr. Sadaf, for this insightful talk. And we learned a lot and the latest advancements in the sympathetic blocks. If anyone has a question, please ask.
Assalamualaikum. Can I ask question, please?
Yes, please.
Hello, ma'am. I'm Dr. Asim. I am working as a consultant pain physician in King Salman Medical City, Medina. Thank you very much, Dr. Sadaf, for a very comprehensive talk regarding the sympathetic blocks and chronic pain. Just want to ask that is there any role of neuromodulation of these sympathetic ganglia in spite of blocks in chronic pain? And have you any experience of this?
Thank you so much, sir. Sir, I'm sure if you know about Pakistan, there is no neuromodulation technique is available to the best of my knowledge. So maybe somebody else can share their experience on that, or if you have any experience regarding that, you can share. Here we are in the sympathetic ganglions, we are using we are giving the diagnostic blocks with the steroids and local anesthetic. And if we need to repeat it or if we are treating the malignancy, we are going for the neurolysis, which for which we use the phenol and alcohol. And sometimes we go for the RF that for the ganglion empire block. I hope I answered your question. If you are using some advanced these spinal stimulation, spinal cord stimulation or advanced techniques, you can share your experience with us.
And this is not about the neuromodulation of the spinal cord. Basically, this is the neuromodulation of the sympathetic chain or ganglia. And just want to ask this: is there any literature you have searched so much for this topic? So, is there any literature or your experience? Definitely in Pakistan, I know that other than only 1 or 2 cases of neuromodulation in the last few 5, 6, 7 years. So, just want to ask for the residents who are taking this lecture, so academic purpose also. Here in Saudi, we are using this neuromodulation techniques for chronic pain of for many reasons.
Ma'am, Assalamu alaikum. I have a question regarding use of phenol and alcohol in chemical neurolysis. My question is, which one is superior and long-lasting, uh, phenol versus alcohol?
Thank you, Dr. Jamal. Sir, the literature that I have searched is that both phenol and alcohol can be used. Both of them, they are being currently practiced everywhere in Pakistan, outside Pakistan. The added advantage of using phenol is that you get the block for a longer duration. So again, it depends on the clinical condition of the patient and the block you are doing. Both can be used, and uh, the duration is more with the alcohol.
Thank you.
There is another question by Dr. Mozam Ali. Is there a way to sustain the sympathetic activity as it is while blocking the pain so that we can minimize the side effects of the block?
Sorry, I didn't get it. Way to do?
Actually, I think Dr. Mozam is trying to ask that the sympathetic activity can be sustained while we'll perform the sympathetic blocks just to relieve the pain. Like, is there any way we can just relieve the pain of the patient by performing sympathetic blocks while that very ganglion can continue with sympathetic activity? Is there any way?
To the best of my knowledge, I think it is whenever we are giving a block, so some we can prevent it, or we can adequately co-load the patient, and we can take the precautions to minimize the those effects, but we cannot just absolutely avoid it.
Truly. Actually, definitely, we are blocking the whole activity of the ganglion itself. So we can only take preventive measures rather than sustaining that very activity from the ganglion itself. Any other questions from the participants?
Madam, I have another question. Madam, my question is there a step ladder regarding blocks, like which, what I mean to say, can we go, be it a cancer patient even, we'll be going with the steroid mixed with LA and then phenol and then alcohol, or we can go for direct chemical neurolysis as well in sympathetic blocks.
Sir, we can go for directly go for the neurolysis. Basically, it depends on the clinical condition of the patient. For example, if a patient is a terminally stage of cancer and his life expectancy is maybe not more than 4 to 6 weeks, so you may directly go for the chemical neurolysis. So it basically depends on the clinical condition of the patients and the indication of giving the block. On the basis of these two things, we decide which needs to be done first. In usual cases, in which we have enough time, we go for the diagnostic block, wait for the response. Sometimes we repeat that block after 2 weeks or 3 weeks. And sometimes in case of the malignant patient, in the cancer patients, in stage 4 cancer patients with very much life, with very few or very less life expectancy, we directly go for the chemical neurolysis. So it basically depends on the clinical condition of the patients and the indications for which the block is being planned. I hope I answered your question.
Ji, madam, thank you.
Dr. Sadaf, can I say something, Dr. Aksar? Or are there any other questions to be attended?
No, please proceed. There are no questions, I think, so far.
Yeah.
We have.
Thank you, Dr. Aksar, and thank you, Dr. Sadaf. My name is Dr. Talal, and I'm the General Secretary of Pakistan Society of Anesthesiology, Karachi chapter. On behalf of the society, I would really like to thank you for taking out your precious time, delivering such an informative lecture, and contributing towards our aim of increasing the knowledge of all the anesthesiologists working in the country. Thank you so much, Dr. Sadaf. And I've heard your lecture. It was a very, very comprehensive lecture. And I hope that the participants must have learned a lot of things from this lecture. Thank you so much, Dr. Sadaf.
Thank you so much, Dr. Talal, for having me. And I'm sure that you and your whole team are working very hard. And you are actually the real strength and the force behind this academic activity. Thank you so
Thank
much.
you so much. Thank you. Thank you. Thank you, Dr. Aksa.
Thank you, Dr. Dalal, for closing comments. So we have time, and let me check if anyone has any question. Okay, so I request everyone to fill the feedback forms. I have provided the link in the chat room. And thank you, everyone. Thank you, PSA Society, and thank you, Dr. Sadaf. I think we shall be closing this Zoom window, and we will have the recording available after a week or so. Anyone who has missed anything can hear that recording. Thank you, everyone. Thank you, Dr. Sadaf, once again.
Thank you, Dr. Aksa. Thank you for having me.